you can see here that I've just removed this really nicely, and it's a whopping post, huge cast post there. See, there's a little tiny bit of GP remaining, hooking out this remaining piece of GP, and it's a very beautiful feeling getting a GP cone out of that. To sort of tack bond, and this keeps the rubber dam out nicely. But look at how many paper points I've had to use there. I think my practice principal would have a baby if he saw that. So hello, welcome today. Again, we're at my Liverpool practice today, and we've got epic. This is almost like an Odyssey of everything that you would essentially do with a root canal, and it's a fantastic case. It's got loads and loads of learning points, essentially what to do, how to temporize a crown, how to remove a post, how to remove GP, how to apically gauge, how to make sure everything's dry inside, how to obturate. What I would say is that before we get into the case, I want to ask you a favour, okay? So when we look at the analytics of the videos, we can see that around 50% of the people who watch these videos regularly are not subscribers. So if I could ask you to do one thing, please just like and subscribe all the videos and the channel. It supports the channel, and if you hit the notification button, you get notifications of new videos. And if you want to bring the support even further, we've got a membership program. The membership program gives you early access to content. It also gives you exclusive content. We've got an amazing access video there. So if you could support the channel, it'd be fantastic. So we look at the case. This is a case of an upper right 1. Okay, so this patient had a root canal and a post crown done many years ago. So the patient had a draining abscess on this tooth, and this had been picked up by their normal dentist, and it was referred to me to resolve this issue. And what I'm concerned about in this particular case, when I look at this x-ray, is about how many hurdles we've got to overcome before we manage to save this tooth predictably. And the first hurdle, of course, is removing the crown and checking its restorability. Although when we look at the tooth intraorally, we can see that there is a ferrule noticeable all the way around this tooth. And in fact, this ferrule on the one hand gives us a lot of space above the gum line for the crown to fit onto. In fact, it's aesthetically isn't great. So when we place the temporary crown, it looks a bit longer than usual, but that's something that has been consented to the patient, and also that's something that's going to be managed by her normal dentist, if it's managed at all, of course. We've obviously once we've checked the restorability and we take the crown off, we've got to take the post off. We've got to then check for fractures, because this is a tooth that's got a real strong possibility that it's fractured. And obviously we've got to remove the GP, we've got to then obturate and clean it. So there's loads of little hurdles you've got to overcome in that case. And when we speak to patients during the consultation period, we've got to be very mindful and very explicit about what exactly can be achieved and what are the chances of survival, etc. But I feel like in this case, you know, if we take the crown off, we take the post out, and it all looks good, I think this tooth's got a good shot at survival. Her other options, of course, is to just remove the tooth, and then, you know, maybe have a bridge, or maybe have some kind of implant or denture. Another thing you notice here on the upper left one, there is actually some decay measly, and that will be addressed later on in the video. So we'll move over to the to the video here, and the first thing I'm going to do is I'm going to take an alginate sectional, and this is because when we lift the crown off, we're going to need some kind of index to place the temporary crown back on. I can't tell you the amount of times I've forgotten to do this and had to make it chair side. But once we've made our alginate temporary, we're going to start by cutting the crown off, and I do it a kind of an old school way. I don't have any of these kind of specialized crown removers. I just make a channel down the middle of the tooth, and then use an ultrasonic to try and undermine the crown a little bit, and then just use an excavator to elevate the margins. And usually what happens is if you give it enough persuasion, the crown tends to lift off. And straight away we can see here that there is significant tooth tissue above the gum line for us to save the tooth. And sometimes when you take these crowns off, there's not a lot left behind, but in this case we know it's all good. Straight away what I'm going to do is I'm going to put the rubber dam on. I'm just using a just checking that the clamp fits in this case, because a lot of the time these sort of butterfly clamps there, the beaks are too big, too small, or whatever. And then once we've isolated the tooth, I'm going to use a little bit of a normal ultrasonic to try and remove any of the sealing material which is used to fit this post on. And then I try and use an excavator here just to try and lever out the post, but it's absolutely solid. So maybe I can see there's a little bit of movement there, but it's not that obvious in this case. So what I'm going to use is I'm going to use a dedicated post remover. So I'm using my endodontic ultrasonic unit here, but this is going to be turned up to the maximum. And this ultrasonic tip just vibrates the post, so it breaks that kind of contact between the post and the tooth. And we can see here that still using the excavator, no luck at all. Got to be careful not to damage the tooth tissue. And then now what I'm using is an ultrasonic and the excavator at the same time. What a lot of people like to do is use two ultrasonics at the same time, so extra vibration, but I don't have two endo units, so I'm just giving the post a good old vibration, a little bit of persuasion. And then what I notice now is that as I use my excavator, this post is now moving, and you notice there a little bit of the dentin had chipped away. This is unfortunate, but it's a very, very thin bit of dentin. And likely would have just been sort of fractured regardless, however I would have used, whatever technique I would have used. But I still feel like there's enough above the gum line for this tooth to be saved. And you can see here that I've just removed this really nicely, and it's a whopping post, huge cast post there. And then in the first instance, I just want to give this post holder a real good clean, so I'm just using an ultrasonic tip here just to remove everything. And really what I want to do is just visualize inside the post hole, just to see if there is enough what we're sort of dealing with essentially. So once we've removed the post, I'm going to just use the screw and pull technique with the headstrong file. And as I sort of push this headstrong file to length, I feel like I'm really close to the end. I've got a gut feeling. So I hook it up to my apex locator, and straight away we scream out the end. So I know that the headstrong file is all the way to the end. We obviously adjust the length until we get our zero reading properly, and we found out the working length is 17.5. Remember, it's lower because there's no crown on the tooth. That's something to take into consideration. And then I'm just going to remove the remaining GP with the screw and pull technique. I'm just using different diameters of headstrong files. In this case, I'm using a size 40. And then they can see that most of the GP has been removed, but there's a tiny little bit left. So in the first instance, I'm going to get a HyFlex size 25 variable rotary file, and I'm going to try and remove the vast majority of this GP with this rotary file. And a lot of the times when you just place a rotary file down there and you know the working length, it's just going to drag the GP out. And also you did notice that I'm using a metal syringe to irrigate, because the irriflex tips are usually a bit too fragile for this type of work. But as we have a little look, I can see there's a little tiny bit of GP remaining. And what I'm going to do is I'm going to try and dislodge this now with a specialized GP removal tool. So this is like a DG16 endodontic probe, but right on the end there's a tiny little hook. And these are fantastic, because they're very, very narrow. So when you're looking very, very closely down the canal space, you can see the canal and the GP cone. And then also you can see where the GP cone's been hooked by this little instrument. And you can see here that I'm just very, very gently hooking out this remaining piece of GP. And it's a very, very beautiful feeling getting a GP cone out of that. A lot of times as well, if you're not too sure if you've removed all the GP and you remove a big piece of GP, you can see really that is the end of the GP cone that was in there. So I'm ready to shape with a size 40 HyFlex. You know, there's an argument to say we don't need to do this because the canal space is wide enough for us to irrigate, but I do want to just remove and try and scrape away enough of the obturation material so it's not too difficult to remove all of it. And then I'm going to irrigate and activate the canal space. And I'm doing the vast majority of the irrigation and activation in this case because when I'm going to dress this tooth, what I want to ensure is that any of the intracanal medicaments is going to be able to get into the dentinal tubules. And what I am going to do now is I'm going to place the intracanal medicament in this canal space, and I'm going to measure the tip at the end, because what I don't want to do is I don't want to extrude any of the sodium, the non-setting calcium hydroxide out to the end of the tooth. And it's not the end of the world, but it is associated with post-op pain and possible failure as well. So always really be mindful of length control in teeth. I'm going to backfill the whole canal space with this non-setting calcium hydroxide, and I'm going to place a PTFE tape into the canal space nicely here. And just being really, really mindful, because if you push this down too far, you're just going to extrude the calcium hydroxide out of the end. And then I'm going to remove the rubber dam. Okay, the tooth isn't perfectly sealed, but so I'm going to tell the patient to keep the mouth nice and wide. And this is why we just give the preparation just a little bit of a clean up. Again, keeping the patient's mouth really, really wide, just sort of preparing the tooth ready for our temporary. So a lot of this, the tooth tissue and the post above the gum line is given the old crown something to hang on to, but in this case, because we removed it, I want to just give it an extra prep. And then at the very last moment, I almost forgot the upper left one had a, in this case, it wasn't a decay, it was just a missing filling. So I just very, very quickly replace this with GIC. The referring dentist is aware that this is GIC, and this will be replaced at a later date because this is just part of a wider treatment plan. So in this case, it's just very, very quick and easy for me to place a GIC in this tooth, although not something that I like to do routinely, but in this case I feel like it's clinically acceptable. And then I am going to fill my sectional index with Luxatemp. And then what happens is I place this sectional matrices onto the tooth, or the sectional alginate, shall we say, and then my camera battery ran out. And what we don't have is the final preparation of me cleaning this temporary up. But actually, if we move over to this is the second appointment now, we can see that this is the temporary that was placed on the tooth. And remember, we were talking about the difference between the gingival level and the two teeth. So this patient doesn't really have a very large smile line, but this is going to be addressed at a later date. All I want to do is just get something onto this tooth just to seal it off. And then we're going to go straight for our rubber dam, and we're going to do some multi-isolation in this case. Usually with multi-tooth isolation, I go 5 to 5 or 4 to 4, and then place rubber dam clamps around the premolars, just lots and lots of floss. And then I try to invert the rubber dam onto the tooth in question, the one that's having the root canal, but I just don't have any luck with this at all, and I feel like it's probably the patient's lip which is sort of getting in the way. And I suppose in a way that I could just leave this tooth like this, but I feel like if we're using sodium hypochlorite in the tooth, we've got to be really, really mindful of the rubber dam leaking. So what I am going to use is I am going to use just some liquidam, and in this case, I'm happy that the rubber dam doesn't really sit in the in the perfect position, but as long as the tooth is sealed, that's all really that matters, isn't it? So once it's sealed off with our rubber dam sealer, I am going to remove the dressing with an ultrasonic tip. You can, of course, use EDTA to remove non-setting calcium hydroxide. Give it a good old clean out, bit of activation just to remove that sodium hypochlorite. And now the canal is now nice and open and clean and ready really for eventual obturation. However, before we do that, I just want to check the working length, and it's found to be, in this case now, 17.5 millimeters. So it's still the same working length as before. It's really, really important. If I do 2 appointments, I'll always check the working length, even if the tooth has been already shaped, just because sometimes you can lose your point of reference. Sometimes the point of reference isn't so obvious. So just make sure you do that every single time. And then we're ready for our cone fit. So I'm going to get our matched cone here, the size 20 GP cone. And then what I completely forgot is that I shaped this tooth up to 40 in the last appointment. So when I place this GP cone to length, I know that it goes right out the end. I know that this is going to be too long. So what I do is I pull the GP cone out. I know that it's too long, and what I do is I check how long it is. So it's about a millimeter too long, possibly. And I'm going to apically gauge this tooth. So I'm going to get my gutter cutter here. So this is a gutter perker cutter. I'm going to match it to a size 40. Which I should have done in the first place. And then when I fit this GP cone to length, it fits really nice and snugly, and I can feel that kind of tug back. So I know that the end of the GP cone is fitting snugly with the end of the canal space, and we can see now we're at the correct working length, which is 17 millimeters. So we're going to place the cone to length. We're going to, again, feel for that kind of tug back. In this case, what I like to do is I like to just snip off the excess, mainly because sometimes the rubber dam the rubber dam sheet can sort of move things around. And then we're going to take an x-ray, and in that meantime, again, you remember I like to clean and prep the tray ready for our obturation. So I remove all of the dirty instruments, and then I prep the ring with sodium hypochlorite, 17% EDTA and isopropyl alcohol. And then when we look at the x-ray here, we can see that we're really, really nicely to length on this with this GP cone. So we know that we've got good apical gauging, and the GP cone is fitting lovely to length. We're then ready to do our final irrigation protocol. So I'm going to remove the GP cone here, and I'm going to place that into our GP disinfectant ring. It's really, really important because your GP cone is not sterile. So there's a possibility, of course, that you've taken the GP cone out of the box and it's dirty, and then your nurse touches it, and then her fingers are dirty, and my gloves are dirty. So you want to make sure that the GP cone's nice and clean. We're also going to need to use a file to introduce the bioceramic to the whole length of the canal space. So I'm going to disinfect that. And then what I noticed straight away is the dam seal has come away with this. And what I think I want to do is I want the dam really need to be pushed a bit further down. I feel like that's probably going to be a bit more of a consistent way of sealing this dam off. So in the first instance, I'm going to place another big blob of this rubber dam light cured sealer onto the tooth to try and push the sort of dam away. But the problem with that, of course, is the dam's quite tight, and there's not a lot of bonding to this to this tooth using this this sealer. So once we let go, it moves away. And then I have this crazy idea that I'm going to use kind of like a bridging technique, but again, there's no bonding with this sort of blue composite, so we're not having any luck at all. So, and this bridging technique doesn't work. So I'm going to try some wedges. You've seen some of my videos in the past where I use kind of wedges to sort of move the rubber dam out of the way. The problem with this is there's nothing really for the wedge to wedge out. So finally, I just need to use some composite, and I'm just using a self-etch composite here, just a dot bond. I'm using just some normal, very, very cost-effective composite here to sort of tack bond, and this keeps the rubber dam out nicely. Problem with this, of course, is I don't like to bond composite onto teeth because we want to be prepping this tooth at a later date, and maybe you might damage the tooth trying to remove this off. Luckily, in this case, when we did remove the composite, everything was absolutely fine. And then we're going to do lots and lots and lots and lots of irrigation of activation. you know, I've got an hour and a half for this appointment, so I'm just going to keep going on and on and on and on and on. Although halfway through this, I'm worried about extruding some of the irrigants out the end, so I'm just going to make sure I'm measuring the irrigation tip with a small rubber stopper. I don't want to push any of the sodium hypochlorite out of the end. And then again, back in, lots and lots of cleaning, lots and lots of irrigation, lots and lots of activation. And then in this case, I'm ready to dry the canal space, and again, I'm worried about pushing the paper cones out of the end of the tooth, because paper cones, when they touch vital tissue and then you tear it, is a really, really easy way to create bleeding. So in this case, I'm using like a kind of master paper cone here. So I've measured a paper cone to the correct working length, and then rather than me placing these clean paper cones into the dirty measurer, I'm going to use this kind of a master paper cone here as like a kind of a gauge to know where to crimp my paper cones. And what you'll notice now is I have to use about 50,000 paper cones here to make sure that the canal space is nice and dry. And trust me when I say this, is that you really genuinely need to make sure that this canal space is clean and dry. And if it isn't clean and dry, your sealer won't work. And a lot of the times what I've done in the past is I've done this for many times over and over, and I've not been able to get the tooth dry. So we've had to dress it with non-setting calcium hydroxide and get the patient in a later date. But you can see here now we are pretty much almost there with drying this tooth very, very nicely. But look at how many paper points I've had to use there. I think my practice principal would have a baby if he saw that. He'd be really, really upset, because that's a lot of paper points. But overall, we're ready to do the final obturation. I'm going to prepare the GP cone. I'm going to dip it in isopropyl alcohol to get rid of the sodium hypochlorite residue, and also to dry the cone really easily as well. I'm going to dry it off finally with a 3-in-1 tip. I'm going to place this to the side, ready to go. I am going to use a resin-based sealer in this case, because I wasn't too sure if I needed to backfill this tooth with heat. It transpires that I don't need to do that, but what I want to do is I want to kind of future-proof myself. What I don't want to do is use a bioceramic in this case and then having to sort of backfill this tooth with heat, and then this would affect the bioceramic. So I'm just very, very gently pushing this GP cone to length, and now what I'm doing is a tiny little bit of a pumping action, just a little tiny bit, and then I'm just going to cut off the excess with my heated plugger. And in this case, I'm not going to push this too far down. I'm pretty happy that this is filling the canal space really, really nicely. Of course, the difficulty with trying to remove excess in a small diameter canal, it can be really, really difficult to do this without pulling out the whole of the GP cone. But overall, we can see now that I'm going to condense this down with the Mach 2 pluggers. And this is, you know, I've apically gauged this GP cone, so I'm not worried about pushing this out of the end. Not worried too much, shall I say. But overall, the Mach 2 pluggers are working really, really well. We're giving it a good old clean here, maybe a bit more of a tidy up with a heated plugger. And then I feel like there's probably a little bit too much GP cone in this canal space, really, for us to place this post. So I'm just going to remove the excess. And a lot of people don't like doing this, but I just place the heated plugger onto the end of the GP. I activate it slightly, and I just like to pick very, very small amounts of GP out of the canal space in a very kind of in a patient and in a just a very, very gentle manner, essentially. And we can see here that I've just activated the heated plugger. I take a tiny little bit of the GP cone out, and then I tidy it up with a Mach 2 plugger. And again, you know, in the thick of it, I forgot to show you how I made the temporary in this case, and now forgotten to show you the post placements. And I'll tell you why. Before I place the post, what I want to do is take a cone fit radiograph to make sure the GP is at the correct length. And to save on storage, I just turn the camera off, we take the x-ray, get the patient back in. And in this case, you know, I was just so busy I forgot to turn the record button on. So what we do is we get to the video now where I am placing the sectional alginate on with the Luxatemp inside, and you've got to make sure that the Luxatemp is set all the way before you pull the sectional alginate off. And the first looks absolutely terrible. I don't know what it is. I feel like sometimes that if anyone uses Luxatemp, I feel like maybe the first go with a crown for the first day, I don't know if something's wrong with the material or whatever, but I always feel like the first one never works. So this is a bit annoying because we've got to clean up the prep first before we can do another, because I want to create like a kind of monoblock of a crown. I don't want to create like a kind of a messy sort of inside. So we have another go with the temporary, and then when we pull it off now, it looks pretty good, although it looks a little bit like it's not quite set yet, and it needs a hell of a lot of cleaning up. So I'm going to just keep that temporary on for now while it's fully set, and then what we do is we just give it a good old clean out. Obviously the gum looks super red raw, mainly because the hypochlorite is been touching the gum. So this is the problem with not sealing a rubber dam perfectly, but we just try our best, don't we? And when we look at the post-op radiograph, again, looks really nice. We've got a little bit of obturation sealer puff here. We've got a really nice solid obturation, and overall nice little job, nice little case. Again, if you haven't subscribed already, please hit the subscribe button. It's free, it's easy, it takes 2 seconds. And if you want to support the channel more, we've got the membership program, early access to content, and we've got exclusive content. And I will see you in the next video next week. Bye bye.